Okay, I'm not sure whether the slides will change automatically or I'm expected to change them. I'll just start introducing Samia Hurst. Well, we just heard from Corona Lona, is it correct? That Corona was flying partly under the radar, and I tried now 45 minutes to make something out of Samia's name in combination with Corona, COVID-19, but I came not up with a good idea. But I think the analogy is quite correct, that we have, from her perspective, certainly so many things that were also under the radar, that were not covered by infectious numbers and numbers of vaccines and so forth. And so I'm very much looking forward to that. But let me quickly introduce Samia. Samia is a physician bioethicist. Well, she is not probably she is the bioethicist in Switzerland. So there is barely any council, committee, society, editorial board, advisory group without her name on it or without her name being on it at a certain point. And often she plays a central role in all these communities. At the moment, and I will reduce it to that, not to make it too long, she's the director of the Institute of Ethics, History, Humanities at the Faculty of Medicine at the University of Geneva. And I very much looking forward to her talk because social scientist as I'm of course not only interested in all the possibilities that are there from a biomedical perspective, but also a question she's addressing, like what health policies are most justified and why, and so should we always do what is technically possible, and what do we do if resources are rare and scarce? And of course, in a crisis, all these questions become even more important. And so we are, it's probably not a surprise that she was on the task force, the Swiss COVID task force, and it's also not a surprise that she was vice chair there. As I mentioned before, she always plays a central and a key role. And so she also did or still does in the steering committee of the NFP 80. I'm very happy to have her in the steering committee, and now on stage, please welcome Samia Hurst.
Thank you. Thank you very much. I'm very happy to be here, and particularly happy about the start of PNR 80. When I was a young medical student, because I have a background in medicine before having another background in ethics, when I was a young medical student, in our public health classes, one of the first messages is that cultural aspects that we disregard are where public health goes to die, and that humanities have to be a part of epidemic response. Now, little did I know at the time, I learned this in clinical care later on, and then in being a part of pandemic response even later on. This was actually just the first chapter of the interface between what happens in pandemics and the human and social sciences. The second part is that epidemics are a whole life impact. They impact us not just physically, they impact our biographies, they impact our communities. This is, of course, also true of diseases in general, but it is even more apparent in epidemics. And the last chapter is that epidemics, and in particular pandemics perhaps, also show us things about ourselves. Sometimes it's things we sort of knew before. If you ask people about what they learned, what was a real surprise, many of the things that we learned are perhaps not entirely a surprise. And sometimes they are things that we sort of didn't like to learn, but they are nevertheless important. A disclaimer, though this audience perhaps doesn't need it, but I like to have it there. The pandemic is not over yet. It's not over in the world. It's not even quite over in Switzerland. And anything we can see at this point is tentative. One of the purposes, indeed, of this NRP 80 is to enable us to complete and revise this picture. I very much look forward to having other things on these slides in a few years' time. But let me take you back to the very first stage of this crisis chapter, this initial crisis chapter, which is now over, of the pandemic, and to this mental state in which we were in, this very particular mental state with these empty cities all over the world. And with this wave that was going up, the first wave, and we didn't know what would happen yet. You remember seeing this image going around online, probably, with very hypothetical scenarios. This is not real modeling. This is something someone drew on a piece of paper like that, your open hand drawing of what might happen if we did nothing, or if we did a few things, or if we really did more things. And the time was then. Oh, okay, it works. The time was here. And several of us at this time got a phone call or an email saying, please come tomorrow. And most people who got this email or this phone call did come tomorrow. And one of the things that, it wasn't immediate, but one of the things that happened was that Swiss pandemic response included the Swiss Science Task Force. And I want to say a few words about this because at this juncture of the closing event of NRP 78 and the kickoff of NRP 80, there is room to highlight an aspect of the Swiss pandemic response from a scientific standpoint, which was interdisciplinarity. This is not something that happened in every country, but the Swiss COVID-19 Science Task Force had 10 expert groups, and from the beginning, it had 2 of them in the human and social sciences. Many countries added on the humanities later on, not everyone did, but Switzerland had the humanities from day one. One of the groups was centered on economics, and there are several researchers who participated who are also part of projects in NRP 80. Another of the group was on ethical, legal, and social issues, and there again, there are projects in NRP 80 carried by researchers from this group as well. Now, a few words about the work of the Science Task Force. This was consultation, so it wasn't research. Research projects did get identified, but got earmarked for later. We had to work with the current state of knowledge and uncertainty. This was collective intelligence. We crowdsourced a lot. I'll show you a few names on the next slide. And this was interdisciplinary, which sometimes meant that things that seemed obvious to some of us had to be said nevertheless because they were not obvious to everyone. And I'm sure all of you who have experience in interdisciplinarity know the phenomenon I'm talking about. We tend to get siloed into our own fields and imagine that many things are common knowledge when really they're not, and we have to do a lot of explaining of things that seem very basic to us. The fact that it was consultation also means that when you give data and provide advice, people don't always follow this advice. Now, we crowdsourced, as I said, and one of the things that we did was we worked through the Swiss National Science Foundation. I can only speak to the interfacing done in the LZ group, which I headed, but there were many similar networking efforts done by the other expert groups of the task force as well. Just to give you an idea, there were up to 80 experts in the Swiss Science Task Force at any one point. A total of 93 people went through it at one point or another. The LZ group, the Ethical, Legal and Social Issues group, there were 5 people, but through the Division 1 of the SNF, we got input from people working in the human and social sciences, and I just list here the names of the people who gave input in one form or another, at some point or another, some a lot, others little. There are junior researchers, senior researchers in there. I counted 77 of them. This is a huge amount of people who donated time, and I want to take just a minute here, especially because this is recorded, to thank them, and also to tell you, if you're watching this now in this room, or if you're watching the video online later, I got this list of names from the common documents that we used as our working tools, and I looked into my emails as much as I could, but I may have forgotten people. If I did, if you don't see your name on there and you really did give a contribution, please write me, and I will add them in next iterations of this talk. But we really wished that we would have had the sort of data which the NRP 80 is designed to bring to light. We really wished that we would have had the sort of information about the social and human aspects of pandemic effects that we're now going to have in the next few years. It is really important to have this PNR 80. It would have been even better to have 2, one during the pandemic and one after. You can't have everything, though. So this first aspect is humanities need to be a part of pandemic response. But the other aspect is pandemics affect us on a whole life basis. They are a stress test for societies, for whole societies. Epidemics, in other words, threaten our lives. It is almost trivial to say it like that, unless you understand that it means our whole lives. They threaten our physical and mental health, very obviously, but they also threaten our biographies, they threaten our connections, they threaten our identities. The stories we tell ourselves about ourselves and to each other about each other are fundamentally modified by epidemics. They threaten our communities. And in theory, at least, it is entirely possible to emerge from a pandemic completely physically unscathed, but having lost irreparably in these other areas. And if there is a single book out of literature that I would like to recommend you read, if you haven't yet, because by now many of you will have read it already, it is José Saramago's Blindness, where he imagines a completely made-up disease that strikes people with blindness. And I'm going to spoil a little bit, so move ahead 5 or 10 seconds if you're watching this online, if you want to read it and haven't yet. In the end, people recover. But in the interval, while they were blind, the whole society unravels. And it is not clear at the end of the book how it can ever stand up again. So this is the imagination exercise of societal impacts of an epidemic that ends up not directly killing anyone. This effect on the rest of our lives. And of course, these risks are not evenly distributed. We do not have the same means to survive and defend ourselves in such a situation, and this means that very predictably there will be an uneven distribution of all of these risks. Pandemics are also situations where we must do things together on a more demanding scale than is usually the case. Cooperation is a human superpower. We are able to do together quite astonishing things that none of us would be able to do on our own. But the demandingness of this cooperation in a pandemic situation becomes greater. This is why it shows us where we are able to rise to the occasion and where we are not. It shows us our strengths and our weaknesses. It demands more of us. And one of the things that it demands more of in particularly difficult circumstances is trust. Trust, which is the ingredient of cooperation. Trust becomes greater, the need for trust becomes greater in a crisis, but at the same time, it is also more threatened. It becomes more fragile. If we feel anxious, precarious, under threat, trust is harder. We tend to focus on a smaller circle. Actually, in Switzerland, this focusing on a smaller circle of people was sometimes protective. You may have noticed there were times when it looked like the virus did not jump language barriers, as if there was a physical barrier between the language regions. Sociologists told us at the time that the most likely hypothesis was that when people moved into their inner circle and stopped seeing people in their outer circle, very few people have a bilingual inner circle. We tend to live next to each other and interact on the outer circles between language groups in Switzerland, but if you focus on your inner circle, it's likely to only speak one language, and this made sometimes, for a time, the language frontiers tight to the virus to some degree. But so trust becomes harder and more important, and trust rests on representations and expectations. And it's important to understand this because representations and expectations can be mistaken, and so trust can be mistaken, and this can further endanger it. One of the first pieces I wrote during the pandemic was a blog piece in the Journal of Medical Ethics called Accepting Trust for Pandemic Response. We need leaders to think twice. And this piece was inspired by very important and clarifying work on trust done by a British philosopher. Dame Honora O'Neill has one of the most influential accounts of trust currently published. And on her account, trust is never entirely blind, nor entirely given. We trust, she explains, if we believe that a person or a group will do a specific thing in a manner that is competent, reliable, and honest. And this means that we can trust for very precise things and not for others. Trust, in other words, is often misunderstood. It's not about liking someone. You can like someone and distrust them. You can not particularly like someone and trust them. Trust does not have to be reciprocal either. I trust you, why don't you trust me? is a sign of misunderstanding. I am married to a surgeon. I would trust him to operate on my appendix, but he would be very, very foolhardy to trust me to do the same to him. I do not know how to do this, right? So trust does not have to be reciprocal. And this means, of course, that in order to know if you're going to deserve trust, you have to know what is expected of you. And if things are expected of you which you do not know, and which you do not explain, you can't do, you will inevitably betray trust. Physicians know this. We have patients who come to see us with an implicit expectation that we will be able to make them immortal. They never say it in so many words, of course, but the expectation is whatever happens, you'll be able to save my life, right? And that is the same as thinking we can make them immortal. And we can't. And if we don't explain this, if we accept this trust, of course, we will betray it. You have to know what is expected of you. So what was expected and what were legitimate expectations in pandemic response? This is an interesting question. And the first shot at it, but it's only a first shot, is that governments made a contract, usually implicitly, with us, with the population, where they asked us to make sacrifices, take on burdens, make choices we would not have made otherwise, face risks. And in return, they committed themselves as far as they could, because you can never commit yourself to more than that, as far as they could to protect our health, that was the visible part, but also to protect our rights and to protect our subsistence, to provide a sort of bridge to the other side. So if we look at these different chapters, we can examine the different aspects and how it played out with the human and social sciences on each one. The first slide on this series, I will go quickly over. You have seen these numbers. Switzerland didn't do too badly in terms of deaths, but I checked, of course, Denmark did do a little bit better. But on distribution, there was a social stratification. This is something that was shown in country after country after country. You did not run the same risks of becoming ill or dying, even on this very simple outcome measure, depending on what socioeconomic group you belonged to, not just age. Age is a factor, of course, but also how well off you were. Now, this is with the usual way of looking at socioeconomic factors, but very early on in the pandemic, there was quite a forward-looking paper written by an economist in the US, Robert Reich, who wrote a journal article called COVID-19 Pandemic Shines a Light on a New Kind of Class Divide and Its Inequalities. And he describes 4 groups, which he describes as follows. The first is the remotes, sorry for the typo, those who are able to telework, to batten down the hatches, stay at home. They'll be stressed out, bored or anxious with kids out of school, but he says they're well off compared to the other 3 classes. The second one is the essentials, people who can't stay home, who must work in the face of danger, often without personal protective equipment at the beginning. And he says of them, too many essentials lack adequate protective gear, paid sick leave, health insurance, childcare, especially important if schools are closed, and they also deserve hazard pay. A moment to pause here. We are now at the time when many of the people who became ill in the course of essential work, and some of them remained ill, are now losing their jobs. Right. So this is another situation that is an effect that is lowered, that is further down the line, that we have to be attentive to. The third group is the unpaid, the resulting desperation of those who lose their pay during the pandemic because they did not get support from their governments where they live, because they cannot work. This is what is fueling demand to reopen the economy long before it's safe. And it also comes down to a choice between risking one's health and putting food on the table, and many will take the latter. So it also drives unofficial work, and people will then take risks of becoming infected in order to not run the risk of becoming destitute. And the fourth group he calls the forgotten. These are people who are institutionalized, unable to socially distance, or who live on the streets. All such places, he says, are becoming hotspots for the virus. These people need safe spaces with proper medical care, adequate social distancing, testing, isolation of those who have contracted it, and few are getting any of this. So this is about protecting health and protecting rights. And the next chapter also is about this because, of course, when you have a lot of need in terms of healthcare at the same time, you get into issues of resource allocation. And this happened to be one of the topics I had been working on for 20 years before the pandemic ever hit. And so I was part of the group that wrote the guidelines on triage in intensive care for the Swiss Academy of Medical Sciences, because you need to have worked on something for 20 years in order to write a draft within a week. And that's what we did with the initial draft before it went out for consultation. There's a lot of stuff in these directives, and they have been revised 4 times during the first crisis stage of the pandemic with really substantial improvements every time. But ethically, it comes down to doing as much good as possible, at the same time recognizing the equal value of all persons and protecting professionals. Now, how did it work in practice? What we found out in this mirror of the pandemic is that speaking about fair allocation is something we know how to do. But then how do we apply it? And one thing we found out is we do not dare to say that we are applying it. This is a figure out of one of the policy briefs of the Swiss National Science Task Force that looked at the second wave in 2020. And here you have the first green line is the projected number of hospitalizations based on the projected number of hospitalizations per case that was happening. And the second green line is people who actually were admitted to intensive care. So there's a big gap here. And this was being followed in real time. This was not projected cases. This was real life cases and projected hospitalizations. So there are different hypotheses to explain this. Maybe there was improvement in treatment and people didn't need hospitalization that much. Well, no, because then we should have had a decrease in mortality, and we did not have that. Or maybe there was a shift in the age distribution of cases, and people who were sick were younger and needed less admission to hospital. But actually, no, it was the opposite. There was an increased mortality pointing to older patients than in the first wave. And actually, the most likely hypothesis is that informal triage took place. And at no point in the pandemic was there ever an official hand raise and say, now we have to use these directives. They were never used officially, but the data looks very much like at some stage, perhaps not even in intensive care itself, right? Perhaps uphill at hospital admission, some form of limitation happened. Another thing we learned, but perhaps just confirmed, is that we are, in our organizations, a work-centric society. One of the things that we heard a lot was, well, we are confining for the old. And it's implied that elderly people were the beneficiaries and the others sacrificed. But if you look closer, a more complicated picture emerges. In fact, our social organizations exist to protect us, to enable us to make certain choices, to exercise certain rights, to live our lives without having to risk them too much. And COVID-19 changed the circumstances, and temporarily, to continue having the same goods out of our social organizations, we had to reorganize our organizations. But actually, reorganizations focus first and foremost on the working population. In the different spheres of society, professional activities got the first focus and priority for reorganization. Family life, the commons, associations, all the rest came second, and sometimes not at all. We focus far more on the working population than on the young, the elderly, and now the immunosuppressed. We reorganize the functioning workplaces and not access to the components of life for everyone. And that was a very important fact. We also learned or confirmed that we are an ableist society. We entered the crisis stage with very little accommodation for people living with disabilities, and even with many other disadvantages. And actually, when we exited, I have a postdoc who is doing a study now on the experiences of the pandemic among people who are blind. And one of the first things that her participants told her is, when are they going to start helping me on the bus again? Every measure is ended now, right? So we should have gone back to normal, but it seems that instead of going back to normal, in many instances, we came back to easy. And it is not the same thing. Now, this focus on work meant that there was a little sentence that many government representatives said at the end of the first wave, at the end when we deconfined. And the Science Task Force made out of this little sentence its only scientific publication in a journal of the first phase of the pandemic. And this little sentence was, we can all go back to our lives, but of course, the vulnerable have to stay confined. And we thought, well, how long? And what does it mean? right? And how is that really protective? And we wrote first a policy brief, then an article on continued confinement of those most vulnerable to COVID-19, where we outline all the different aspects of the implications of this little sentence that went mostly uncommented otherwise. Now, when we speak about allocating our efforts, we speak about allocating hospital beds, we also have to speak about allocating vaccines. Countries usually had very nice vaccination allocation procedures within their country. It was different from one country to the other, but there was always a reason why, and it was explained and it was transparent. Of course, on the world stage, things looked very different. On the world stage, put bluntly, countries did not share. And although we have to say there was more sharing in this pandemic than in previous ones, the margin of progress is still immense. And this is one of the things we have to learn out of this, is that we need to do better on the chapter of international cooperation. It's important as well because cooperation is also about reciprocity. In 2009, there was a beginning of an outbreak of influenza in Thailand. And because of issues of international resource allocation, at one point, the Thai government stopped sending samples to WHO because they did not have guarantees that they would then get a vaccine if it was developed and needed for their own population. We need international cooperation for pandemic surveillance and awareness and early reaction. And so we have to have it on all levels, because otherwise, why cooperate if the system you're cooperating into will do nothing for you in return? On the chapter of protecting rights, I also have to say that Switzerland got two black points from Amnesty International, one on the rights of refugees and asylum seekers, where exceptional circumstances often meant that they had a harder time or an even harder time than usual. And also during the first wave, there was one point at the start of the pandemic where, I'm going to cite, the police lacked clear guidelines to implement emergency measures and disproportionately limited protesters' right to freedom of peaceful assembly by imposing blanket bans on demonstration in public and handing out fines in certain cantons. This was only initially. In the next waves, even when we had restrictions, there was always an exception for peaceful demonstration. But here you have an example in April of 2020 where demonstrators in Tel Aviv showed the planet that you could do a COVID-safe demonstration by filling up the entire city at 2 meters distance from one another. And here you have in June, after the initial ban was lifted in June in Geneva, this was actually a Black Lives Matter demonstration where people basically hadn't gotten the memo about social distancing, although many people are wearing masks, as you can see on the picture. When you speak of protecting rights, of course, it's about protecting rights, but it's also sometimes about balancing them, because you have different rights at the same time, and they're not always compatible. You want to protect different components of people's good, protect the other values at stake. It doesn't always fit. Components of the good for different people are not compatible, and people want and understand different things and have rights that are in tension with one another. So how do you do that? This is one of the ethically fascinating things. First lesson, recognize the dilemma. If you have an important goal, which it would be a transgression not to aim for, and in order to aim for that goal, you need a restriction, which is also a transgression, you have to face it head on. Many people just don't like being in a dilemma and will try to deny the first point or to deny the second one or to deny both. Say the goal is not that important, or say it's not really a transgression. Well, no, the goal is important and it really is a transgression. And there are rules that are reminded, of which we're reminded by the lawyers. There are legal rules, actually, for when you can transgress a right. Usually, they are described as 3 principles: necessity, subsidiarity, and proportionality. And the second message is that in these principles, facts and values are inextricably intertwined. And that is one of the reasons why you get sometimes chaotic discussions, because some of the elements of these principles can be observed, right? Is the goal reachable? Is the means likely to reach it, etc.? But some of them are value judgments. Is it an important goal? What is the degree of this restriction? And here you need to see that science has a very important place in the green bits, but not in the purple bits. This is about evaluation. Another aspect is bringing us to the other side. I will not dwell on this. Others could speak to this much better than I could, but in a nutshell, health and the economy are much more interwoven than people usually think. A lot of the news media like to portray the discussions about pandemic measures about a fight between health and the economy, but actually, if you don't do anything, the economy suffers a lot as well. And another aspect is that you have collective action problems everywhere. You have a public good, which is low case numbers, an intact healthcare system. It's a non-rival good, so use by one does not limit use by the others, and you can't exclude anyone. So someone who doesn't wear a mask or doesn't have a vaccine also benefits from the low case numbers. And then you have situations where everyone needs to do their part for this good to be achieved, and everybody has to sort of think about whether the other ones are going to do their part, because maybe doing my part on my own is not worth it if the others are not doing it too. Should I close bars in my canton if the next canton over is going to have them open? Should I wear a mask on the bus? In Geneva, we had a public survey in summer of 2020 where 80% of Genevese said there should be a mandatory use of masks on buses. But on the buses, you could observe every day that nobody was wearing a mask. And people said, these people are irrational. No, they have correctly understood the collective action problem. If you are on your own wearing a mask, your protection is not all that great. And you get strange looks from everyone. So the cost is high and the benefit is low. If everybody else is also wearing a mask, your benefit is high and the cost is low because you're not getting all these strange looks from everyone. Should I keep my sick child at home, etc.? And perhaps the most challenging aspect of bringing us to the other side has to do with living with our disagreements. This is one of the task force policy briefs on responses to corona denial, where we very strongly highlighted the importance of keeping even very seemingly irrational discourses within the democratic discussion, of not demonizing them. And here I want to point you to very important work, in my view, of the political philosopher Teresa Béjean in the UK, who has as her work focus this art of discussion in this very disagreeable experience we all must live with, of living with people who disagree with us, if we want to live in pluralist societies. Because this is what pluralist societies are, places where people disagree with each other. And in order to remain members of the same society, we have to learn this art of stating our positions, but not making it impossible for future interactions to happen. In conclusions, then, pandemics are mirrors. They show us our strengths, they show us our weaknesses, they show us our values, and sometimes these values don't fit together, so they show us where they don't fit together, and because we must arbitrate, they show us our priorities. This was an article in the international press. Switzerland is choosing austerity over life. And this is one of the things that we saw, right? There were times when money counted, and there were times when health counted. There were times when both were aligned, and when they became disaligned, it was a bit of a struggle sometimes. They show us our priorities. And these can be difficult lessons to learn, but they are important. They are particularly important if they also allow us to learn out of our strengths and out of what we were able to do during such a time of crisis. This is why I have this picture of the Japanese art of mending things with gold to make an object that is then more precious than the initial one before it was broken. This is one of the hopes out of this PNR 80. This is why we are here. I look forward to seeing the results. Thank you very much.
Thank you, Samia. We, again, take some time for questions. There are mics going around, and I'll give it a start. You mentioned that 5 out of 83 persons in the task force and the working groups were from in the ELSI group. Yeah. And you try to make it sound positive that in Switzerland we had this, this perspective in the task force. But we could also say, well, 5 out of so many, isn't that too little?
Yeah, you could say that, but actually this was about the average size of every group, and you had a public health group that was also about the same number, and you had the ones doing the modeling that were also about the same number. And as I showed, we were not just us. the point of the Science Task Force was to be an interface with the Swiss scientific community. Now, every group dealt with this part of our mandate differently, but in the Ethical, Legal and Social Issues group, we were very much an interface. What we did is that, and this was largely through the help of the Swiss National Science Foundation, I have to say. The Division 1 leadership was on board from day one, and they would send out the questions that we were working on to all the researchers funded through Division 1. And these were people whom none of us necessarily knew. So of course we knew some of them. Switzerland is not that big, but there were also people who showed up in the shared documents that we had not heard of. We should, of course, but we hadn't, and whom we would not have called on our own. So this was a functioning interface that was very broad. And we also asked them to let it be known among the researchers that if they had issues that were not being addressed by the Science Task Force and which they thought should be, to contact us through the same channels. And this actually happened on a few occasions. So not all of them led to published policy briefs, although some of them did, because what would happen then is we would have a chat with the researchers who'd raise their hands, see how we could bring this forward. And sometimes in the discussion, it actually turned out that there wasn't that much. So for example, we had one such discussion where when someone raised their hand and said, we have to say something about honoring the dead. I said, sure, that's a very important part of it. So we had the chat and we asked, well, what do you think we should be saying? What should be the main messages here? And actually, this person needed to think more, and it ended up never happening. But there were also people who raised their hand and said, we have to say something about visits in nursing homes, and this led to a document. Someone said we have to say something about gender, and this led to a publication as well. So we didn't have all the ideas ourselves. We had dozens and dozens of people who contributed. One thing I didn't mention is out of the 77 names on the slide, 9 were actually not based in Switzerland. Right? So we also had freely given international help from people working in the social and human sciences. And that was quite impressive.
So the mics arrived already at the person? Yes, please.
Thank you so much. I wish we had someone like you in the debate in Denmark. It's really a fantastic point of view you have. I was wondering if you would, have you thought about this business of proportionality? It's something I found was really hard to make people understand this year. A pandemic is a completely different thing than seat belts and secondhand smoke. This is something, if we don't do certain things, some things will go really bad, like in northern Italy, or what the model said. And people had a hard time understanding that proportionality is not just what's right here, right now, it's also what's to come in 2 months if we don't do something.
That's a very important comment. Thank you. So the proportionality is the final criteria. So necessity is that you have an important goal, and of course you have to explain what the goal is. Right? If you don't do that, the thing never gets off the ground. You have to explain what the goal is, and then there has to be some form of decision that this is an important enough goal to pursue in the first place. Because if it's not, you stop there. Then you have subsidiarity, which means you have to choose the least burdensome approach that is likely to give you the goal you want. And here you have to examine possible approaches, which ones are realistic, which ones could be carried out, which ones could not, which ones are likely to be effective, which ones are not. And then you choose the one that is the least burdensome. But here again, you have an evaluation, because burden, you already have some disagreement among reasonable people as to what is most burdensome. And then if you have necessity and you have subsidiarity, it's not enough. You must also have proportionality. It must be worth it. The benefit, the goal must be worth the burden. And this is the mother of all battles. This is something that you're going to predictably have disagreements among reasonable people about. Right? The important thing to understand is proportionality is not about whether or not the measure is frustrating. The fact that the measure is frustrating is a given, because you're in a dilemma, right? There's going to be a sacrifice. You would not even start this reasoning if you had only things everybody wanted to do in the first place. It is because there is frustration that you are going, and not just frustration, but actual transgression, that you are going to be having this reasoning in the first place. Proportionality is whether it balances out. And you will have disagreement about that, inevitably. So you can't expect that a measure will be viewed as proportionate by everyone. What you can expect, however, is that the decision about whether or not it's proportionate is made in a way that makes it understandable for everyone, and that there are there are possibilities of voicing disagreement. That's one of the reasons why having the possibility of political demonstration is so crucial, right? And indeed, they did happen in Switzerland. But we also had 2 votes during the first crisis stage, 2 direct popular votes on COVID measures, where in both cases the population voted yes, right? So there's all sorts of things about decision mechanisms and legitimacy and democracy that get invited into the discussion at this proportionality stage. But that is because you can't expect to have complete agreement. And if you have a requirement for complete agreement, you basically veto everything, right?
Thank you very much. I'm a physician, I'm a clinician, and I think I was exposed to this informal triage during the second wave. And my question is the following. What do you think about that in terms of regional variation, or who paid the price of this informal triage? Do we know that? Can we know that?
So there could be many questions in your question. One of the reasons why the Swiss Academy wanted the guidelines on triage was to support a fair distribution. The fact that it happened informally, at least that the data strongly suggests that it happened informally, does not mean that it necessarily happened unfairly. What it means, however, is that it was intransparent, and so it is difficult to know whether or not it was fair, right? So this is a more risk situation than if it was transparent and documented. Another reason was that we wanted to avoid too much regional variation, and informal triage is open to regional variation, because you are not doing this officially, so you don't know what thresholds are being applied in different parts of the country. Another reason was that without such guidelines, healthcare providers would have been left on the front lines to invent it themselves. And this is not just a risk of error in terms of fairness, it is also an immense burden. And this was to be avoided, right? So our hope, at least my hope, is that the existence of these guidelines were helpful even if they were not officially applied, because it was at least a reference document that was usable even if there was never a sort of green light for its use. But there was certainly a burden, a moral burden, borne by healthcare providers who were doing this in the front lines. And although we can hope that the existence of the guidelines diminished that burden, it is naive to think that it would have taken it away. This is something that is also being measured, right? There are people working on moral distress in healthcare providers as a factor of burnout, as a factor of psychological distress, and this is a very well-known and studied phenomenon. So yes, I take it you were not speaking of financial cost, but there is a great non-financial cost of these situations. Yeah.
Okay, yep, thank you. You mentioned reciprocity.
Yeah.
And gave that example of Thailand, and it makes immediate sense, but we have the lack of reciprocity in so many parts, also when it comes to the climate discussion and so on. How would you establish it?
Well, this is a very good question. You have to want to establish it first. And even when you do want to establish it, it's not easy. Usually people start very small, right? Because you also are establishing trustworthiness, right? We'll take a small engagement, show that it works, and then we build from there. But you have to first have the will to do it. And of course, it's difficult to tell sometimes how much will to do it there is on the international stage. There seems to be at least some, right? It's not zero. You can also take the optimistic view, as I did, that it's improving, because if you look at the way that sharing was done in previous pandemics, the measures that were taken internationally for sharing this time are actually a hope, right? They're going in the right direction, but there is still a lot of work to be done there. Yeah.
Thanks.
Okay, one last question.
This is very bright.
Yeah. Sorry. I wanted also to come back to the triage question. Is it also possible that actually the patients would be suggested to triage themselves out by these patient wills and willings that were, it seems, increasing also during the pandemic?
Okay, so this is a really good question. It is true that one of the things you absolutely do not want at a time of resource scarcity and a big pandemic wave is to fill up intensive care with patients who do not want to be there. Right? That's one of the things you absolutely want to avoid. So it's important to have discussions and see who wants or does not want intensive care in case of life-threatening acute disease. And so yes, there were also statements from many different parties about mainstreaming advanced care planning, about making this part of everyday medicine much more, even more than it is today. This, however, leads to documentation. So if indeed it is the rise of advanced care planning that has led to this discrepancy in the curves, you should be able to document that through the fact that the number of missing people in intensive care is actually comparable to the number of people who did the advanced care planning thing. So that's actually something that is not known currently, but that is theoretically knowable, right? You could go back to the patient files and look at advanced care planning. One thing you cannot do, however, is document every single instance where someone did not call, right? Some of the people must have been at home at first, right? And so maybe people just didn't call. And there you can't know why, right? You can even imagine that some people had this reaction we sometimes see in geriatric medicine, that when there is too much speaking about things like that, you get old people saying, okay, so I'll just leave it for the young. And they don't necessarily say that out loud, they don't necessarily document it. And of course, there's interesting discussions to be had as to whether this is an expression of self-determination or whether it is actually social pressure exercising itself on a vulnerable group, and maybe it's both, right?
Thank you. You're having a short question, short answer? Okay.
I'll try to do a short answer.
Just as an addendum to that, there might be multiple layers, and I'd like to know if there are data to examine what happens in an ER. Right, so once you are in the ER, I'm a pediatrician by training, but I see a lot of bias in terms of who gets admitted, who doesn't. We've done some work long before the pandemic, had a 6,000 children cohort with kids with flu-like illness and respiratory infections. Yeah. And who is getting diagnosed, who gets a diagnostic test, and who is getting admitted is not purely linked to disease severity. There are other factors.
Yeah, so exactly. That's exactly the kind of phenomenon I was pointing to when I said there was informal triage that was taking place and perhaps not in the intensive care itself. Intensive care specialists are used to doing triage on a less hot level every day, right? And they are used to documenting it, and it is part of their expertise and experience. Outside, perhaps not so much. And so if there was no triage at the entrance of intensive care itself, and we have this discrepancy in the two curves, it means it must have happened at some other point in the health system. And of course, the first hypothesis that springs to mind is not its patients self-selecting out. It's that at some other point, there is some bias in the referrals. And of course, the emergency room could be one of these points. It's completely plausible, yes.
Well, thank you. I think all the questions show that it's great that this is not a closing remark of the conference, and we have plenty of time to continue conversation, ask questions, discuss the topics. Thank you very much, Samia, for your presentation. And hold on. Of course, you know the quote from Forrest Gump, life is like a box of chocolate. You never know what you're going to get. In this case, it's also a box of chocolate for us because we don't know what you get.
Oh, I see.
At least I do not know, because when we did research on what is the specialty of Thun, we were told it is Thun fish. But when you Google Thun fish, you get a lot of pictures of tuna. And I assume it's not tuna in there.
Thank you.
I was told there are some sweets in there. Enjoy.
Thank you very much.